and health policy, the root of the nation's healthcare issues, and the trade-offs posed by various proposals for change. We are so thrilled today to be presenting our webinar, Navigating Complex Systems, Care and Policies for Dual Eligible Beneficiaries. The Alliance has served as a trusted educational resource for the health policy community for more than 30 years, and today's discussion will focus on policies that impact the nearly 12.5 million dually eligible people who are enrolled in Medicaid and Medicare. This work is critically important because this is a diverse population that includes seniors or people with disabilities who face significant challenges accessing high-quality healthcare and navigating the intricacies of the Medicaid and Medicare systems. We are excited to showcase different viewpoints and considerations today that will hopefully help you in your work and help to inform solutions for improving our healthcare system. Before we get started, I want to thank our generous sponsors. Today's webinar is supported by the SCAN Foundation, the Association of Community Affiliated Health Plans, Santa Clara Family Health Plan, and the Health Plan of San Mateo. Thank you so much for your support of this program and for joining us today. I also want to share a few quick logistical notes. You can follow the Alliance for Health Policy on LinkedIn to stay informed about upcoming events like this one, and you can also find us on Facebook or YouTube. Today has a Q&A section at the end, and we encourage all of you to be active participants, so please share your questions at any time. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can use that speech bubble icon to submit questions that you have for the panelists at any time, and we will collect and address these during the Q&A. Throughout the webinar, you can also chat about any technical issues you may be experiencing, and our team can assist you. After the discussion today, I encourage you to visit additional resources we have available on the event page on our website. And of course, if we don't get to your question during that Q&A, please don't hesitate to reach out to us at info@allhealthpolicy.org, and we will do our best to connect you with additional information. With that, I am so pleased to introduce our moderator for today's webinar, Allison Hamplin. Allison Hamplin is President and CEO at the Center for Healthcare Strategies, a nationally recognized nonprofit policy resource center devoted to improving outcomes for people enrolled in Medicaid. She is responsible for the overall strategy and management of the organization and oversees the national portfolio, including Medicaid leadership and capacity building activities, delivery system and payment reform efforts to promote accountable care and improve population health, and projects focused on advancing effective care models for people with complex medical, behavioral, and social needs. You can read more about her illustrious background and the bios of our other panelists on the Alliance website today. And now I'll turn it over to Allison to introduce our speakers and get us started.
Allison, thank you so much. It's a delight to be with you today to discuss this important topic. In a few moments, I'm going to provide a high-level overview of dually eligible individuals, including how they become dually eligible, their characteristics, some of the challenges that they face, and introduce a conversation between an amazing group of panelists that we have with us today. And right now, it's my pleasure to introduce them. I'll say that I and my colleagues at the Center for Healthcare Strategies have had the great fortune to collaborate with each of these individuals on efforts to improve integration of care for dually eligible individuals. And so first, it's my pleasure to introduce Dennis Heapy, a person with a disability who is a qualitative researcher and policy analyst at the Massachusetts Disability Policy Consortium, a Massachusetts-based disability rights advocacy organization that is committed to the civil and social rights of persons with disabilities. Much of Dennis's work focuses on pressing for increased accountability among health insurance companies for advancing health equity, grounded in an independent living philosophy and the recovery model of care. Next is Tim Engelhardt. Tim directs the CMS Medicare Medicaid Coordination Office. This office was created through the Affordable Care Act to improve services for individuals dually eligible for Medicaid and Medicare. Prior to joining CMS in 2010, Tim was a consultant with the Lewin Group, and he previously served as the Deputy Director for Long-Term Care Financing at the Maryland Department of Health and Mental Hygiene. And finally, we'll hear from Tom Betlach. Tom served as the Arizona Medicaid Director for almost 10 years, where he reported directly to the governor. He is a nationally recognized thought leader on Medicaid and healthcare policy, known for his expertise in serving complex populations, delivery system transformation, value-based purchasing, managed care, and cost containment. Tom joined Spire Healthcare Strategies in 2019 as a partner to advise government and private sector clients on health policy and strategic initiatives. Welcome, Dennis, Tim, and Tom, and look forward to having you join me on screen in just a bit. But for now, we can go to the next slide. Great, and one more. Excellent, thank you. All right, let's talk a little bit about the dually eligible population. To get us started and focusing on that green overlapping segment between the Medicare and Medicaid circles before you, note that there are currently over 12 million people in the US who are eligible for both programs. Because of their significant needs, their high cost of care, and the complexity they encounter navigating these programs, policymakers at both the federal and state levels are actively seeking ways to improve how their care is delivered. Next slide. So how does one become dually eligible? To do so, an individual must qualify for both Medicare and Medicaid. There are 3 ways to qualify for Medicare. An individual can be age 65 or older, or they can be under age 65 with a permanent disability, including an intellectual or developmental disability, a physical disability, or a disability based on behavioral health conditions. Or they can be of any age if they are diagnosed with end-stage renal disease or certain other conditions. In terms of Medicaid eligibility, the requirements vary by state and are related to an individual's income level and assets, and whether they fall into certain eligible groups, such as older adults, people with disabilities, and people who are pregnant. People with slightly higher incomes also can qualify for Medicaid if they have a significant disability or if they have high medical or long-term care expenses relative to their income. Among the dually eligible population, about half become Medicare eligible due to their age and about half due to their disability. And similarly, on the Medicaid side, about half of full benefit dually eligible individuals also qualify through disability pathways. So I just referred to full benefit dually eligible, so let me explain that a bit further. Dual eligibility can be partial or full. Partial benefit dually eligible individuals have full Medicare benefits, but do not meet the categorical and income and asset limits to qualify for full Medicaid benefits. However, if their income and assets are low enough, they can qualify for partial Medicaid benefits, where Medicaid helps with some or all of the out-of-pocket Medicare costs that they would otherwise be responsible for paying. Bottom line, the key takeaway here is that these different pathways to dual eligibility, whether by age, disability, or by particular condition, result in different subpopulations that have varying but typically complex care needs, particularly those who are eligible for full Medicaid benefits. Next slide. As I just noted, dually eligible individuals are a diverse population, and Allison mentioned this in her opening remarks as well. And importantly, they are generally quite different from people who are covered by Medicare only. People that qualify for Medicare and Medicaid are more likely to be female, from a racial or ethnic minority group, and to live alone. They're also likely to have fewer years of formal education. Overall, dually eligible individuals have more limitations in functional status and more often report themselves as being in poor health. And significant numbers have a mental health condition or use long-term services and supports. In terms of their diversity, I'll note that the clinical and service use profile of dually eligible individuals under and over age 65 are quite different. Specifically, those under age 65 are more likely to have a disability. They are also much more likely to have behavioral health conditions such as anxiety disorders, bipolar disorder, depression, schizophrenia, and other psychotic disorders. Meanwhile, dually eligible individuals age 65 and older have higher rates of physical health conditions such as diabetes, heart failure, hypertension, and heart disease. And they are much more likely to have Alzheimer's or a related dementia. They are also more likely to use long-term services and supports. Next slide, please. These high clinical and support needs mean that this complex population accounts for a disproportionate amount of spending in both the Medicare and Medicaid programs. In Medicare, dually eligible individuals comprise 19% of enrollees, but 34% of program costs. And similarly, in Medicaid, they are just 14% of enrollees, but account for 30% of costs. Next slide. So for someone who is eligible for both programs, which program pays for what? Well, Medicare covers hospitalizations and emergency department visits, short-term skilled nursing facility stays, physician and ancillary services, prescription drugs, and limited home healthcare services. Medicaid, on the other hand, pays for Medicare cost sharing, long-stay nursing facility care, home and community-based services, and most behavioral health services. Next slide. Despite some complementarity in terms of these benefits, there are many misalignments between Medicare and Medicaid that cause difficulties for both dually eligible individuals and their providers. Coverage and payment policies for this population are really complicated, which affects how beneficiaries receive their care. The previous slide showed which program pays for what services, and you may have noted that several services overlap, including nursing facility stays, home health services, and durable medical equipment, often referred to as DME. Let me give you an example of how this plays out in the case of DME. Because Medicare is generally the primary payer for dually eligible individuals, a DME provider must first bill Medicare, and Medicare determines if it will pay for the equipment or not. If Medicare denies the claim, the provider must then submit the bill to Medicaid. This can lead to confusion and delays in the receipt of necessary supports for enrollees. Medicare and Medicaid also have very different administrative processes that impact beneficiaries, providers, and payers. There are separate beneficiary communication materials and notices, separate identification cards, separate processes for enrollment, assessments, and care planning. There are also separate appeals and grievance pathways that people with Medicare and Medicaid must navigate when coverage requests are denied. Finally, I'll note that differences between the two programs in financing and payment rates create incentives for cost shifting and a bias for providing care in institutional settings. Next slide. This lack of integration between Medicare and Medicaid results in gaps, duplication, and fragmentation of care. Our panelists are going to talk more about these challenges and, importantly, efforts that federal and state partners are making to address them. But let me just say that our current separate, uncoordinated systems make it incredibly difficult for dually eligible individuals to access needed care and for providers to deliver and coordinate what's needed. The result is often disparities in access to care. Dually eligible individuals are less likely to have a regular source of primary care or access to specialists, and they are also less likely to receive home and community-based services or hospice care. Ultimately, this leads to disparities in outcomes. Dually eligible individuals are more likely than people with Medicare only to be hospitalized or readmitted to a hospital within 30 days of discharge. They're also more likely to be discharged from the hospital to lower quality nursing facilities and to become long-stay residents of those facilities. With that background, I'm now going to give each of our panelists a chance to provide some opening remarks on the challenges as they see them, as well as what's happening to address these challenges. And Dennis, I would love to welcome you first to share your perspective, so please join me on screen.
Thank you very much. And I'm doing this differently than I usually do it, so if I don't get invited back, that's fine. I understand why. Let me first say the reason why I'm dressed up like I'm in winter is because when my PCA leaves in the morning, I have to dress for the day, and so that means I have my hat, my gloves, my jacket on, and so I can take my dog out, my service dog in training, out after this webinar. You can see behind me, I hate these webinars where you can't put your background in. So I've got my bed in the background, which is a medical bed, and a few other medical devices in the background. So I am one of the medically complex folks who is also dual eligible. We go to the next slide. Yes, thanks. So like I said, I'm doing this differently because I'm usually caught in the weeds and getting very wonky. So this a little bit like at a higher level. Solutions don't work unless people with disabilities are not only at the table with a philosophy of everyone with a disability having a seat at the table. We really want to, if it's about, we want it to be by us. We want to help design the table. We want to be able to design the solutions, not to be brought in after the fact, or to just be one stakeholder out of many. We want to really be part of and in designing that solution. And whether it's folks with disabilities or folks who are older, like the whole dual eligible population. Next slide. Okay. There is no such thing as a single issue struggle because we do not live single issue lives. That's by Audre Lorde, who is a Black lesbian civil rights leader, mom, and poet. And she also had disabilities. And the dual eligible population, as stated, is very complex, and there is no one size fits all solution. And so when insurance companies attempt to fit dual eligibles into a traditional commercial model of care system, it just does not work. People with disabilities are not going to get their needs met. Elders are not going to get their needs met, and the costs are just going to increase. Next slide. I would also say with that no single issues is that's also about health equity, and that in order to achieve health equity, we really have to make sure we're not looking at things in a silo, and that people with disabilities may be African American, and that identity as a person who's African American compounds the impact of disability and ableism. Okay. This one, rights guaranteed under the Americans with Disability Act are only as meaningful as an individual opportunity to access those rights. For better or for worse, people like myself, other folks with disabilities with complex care needs, the only way we can really engage in the community is if we have our basic needs met by our health plans, by our healthcare providers. And that's especially true for when we need long-term services and supports and home and community-based services. And so if I don't have the community-based services I need, the LTSS services I need, the ADA means nothing because I can't get out of my house. I can't engage in the community. So in order for us to actually live full lives, to have the opportunity to live lives that have meaning, we need plans to provide us with these basic services so we can actually understand and receive services that are right under the ADA. Next. Okay. What a person actually needs is not a attentionless state, but rather the striving and struggling for some goal worthy of her. And I'm a big fan of Viktor Frankl's, and it's challenging for people to find meaning and have lives of meaning if they're struggling with day-to-day, the lowest level needs on Maslow's hierarchy of needs. And if someone doesn't have a wheelchair, if someone doesn't have a bed, if someone does not have basic access to care providers they need, then they're not dealing with goals or struggles worthy of them. They're just struggling with day-to-day, getting by and wondering what's going to happen from moment to moment. And health plans have the ability and the opportunity to actually reduce some of those tensions and support the ability of people to move beyond depression, move beyond isolation, to actually engage in activities that support a state of tension that's actually meaningful. Next slide. I don't trust words, I trust actions. There's a tremendous amount of distrust among folks, among dual eligibles, whether it's younger or older people, because the healthcare system often says what it's going to do, but then actually doesn't carry out what it says it's going to do. I was in a meeting this morning, a very painful meeting, and people were talking about lack of communication access by the health plans and how those health plans are not meeting their communication needs. One woman talked about how the health plan required her to use a specific portal, and she's blind, and the portal did not meet her needs, and she was told she had to use that portal. And the woman described it as being torturous, not being able to access the communication the way that she needed it. And so there is distrust. We distrust plans because plans say they're going to provide services, but then those services get reduced, especially community-based services. We see the promise of increased access to personal care attendant services, and yet over time, those personal care attendant services get whittled down, or access to DME. Then over time, the DME service, the access to the DME that's needed is reduced. And so we need to build trust in the system, and it can't just be words, it's got to be actions. Next slide. Okay. We're people, not patients. I loathe the term patient because much of what dual eligibles needs are not medical needs. They really are our needs to lay beyond just the medical. This is socioeconomic, education, housing, social support networks, health literacy, behavioral health, culture and social identity needs, individual goals and aspirations. And these are all from CMS. And these are all identified as drivers of health. And these drivers of health really need to be addressed by health plans in order to support the needs of folks of dual eligibles. Next slide. Is that the last one? Okay. Meaning of person-centered care. Value comes from consumer leadership and governance and oversight of all levels. That's at CMS, state and plan levels. The civil rights model of care. That's integrating independent living and recovery model of care. I can say more about that later. Conflict-free, trust-based care, plan development and implementation. And then also rebalancing services, building systems that focus on addressing non-medical service drivers of health and individual non-medical life goals and needs. I'd also add to this transparency that we need a transparent system that includes oversight by states that have the capacity and the competency to provide that oversight. So thank you. Oh, got it at the last
Dennis,
one. Where you go.
You finished, Dennis.
So we need established measurable goals that matter, evidence-based measures of consumer engagement, impact on the state and federal policies. We need to set benchmarks, and this is more about the service themselves. Reduction in health disparities between disability populations and the general population. Reduction in disparities between BIPOC populations with disabilities and white persons with disabilities. When I say people with disabilities, I don't just mean folks under 64. I mean across the lifespan. Increased investment in home and community-based services, increased investment in non-medical services that address social drivers of health and individual goals. I realize that's redundant, but I appreciate you giving me all the time to present this. And now I turn it over to Tim.
Dennis, thank you. Let's take everything Dennis just talked about and connect it to government policy, right? Because it's an oversimplification. Dennis painted the picture, right, of all the complexities of individual lives and disparities and challenges and everything else. But I can boil it down into like two really broad policy goals related to dual eligibility that happen to be pretty widely shared across the health policy community. And the first, on the next slide, is improving access to the Medicare savings programs. Now, these are the MSPs, I'll call them. Now, despite their name, the MSPs are really Medicaid eligibility groups through which state Medicaid agencies cover Medicare premiums. And in many cases, they cover Medicare Parts A and B cost sharing too. It's what means for many people they can go to the doctor for free rather than paying a 20% copayment that most other people would pay with their Medicare coverage. The MSPs make Medicare affordable for about 10 million people who have low income, near or below or near the poverty level. So the MSPs really improve access to Medicare covered services. They're also essential for economic well-being. When the MSPs cover someone's Part B premiums, that means $174 a month that are no longer being deducted from someone's Social Security check. That's $174 more dollars a month someone can use for housing, for transportation, to put food in the fridge. So, and that's before MSPs cover any Medicare cost sharing for actual receipt of services. So there's incredibly important, almost anti-poverty programs too. So incredibly important. Despite that importance, the MSPs are undersubscribed. There's an advisory body for Congress called MACPAC. In fact, Dennis is one of the commissioners on MACPAC. And in 2017, MACPAC commissioned a study in which they concluded that only about half of the eligible people are actually enrolled in the MSPs. So that means millions of people at or below the poverty level paying what amounts to more than 10% of their income every month just for Part B premiums alone. So you can see this is incredibly important that we get more people who are eligible for these programs into them. Now, one reason for that undersubscription is because of the very complex application and verification process. And the MSP eligibility process is really run by the states, which means there's some variation across the country, and it also means that they don't always align really neatly with other forms of means-tested subsidy programs. We've got a long way to go on this, but there's actually been some meaningful progress through some recent legislation and administrative actions too. A big legislative milestone was something called the Medicare Improvements for Patients and Providers Act, or MIPA. Now, MIPA passed in 2008 and included several new requirements essentially to improve access to the Medicare savings programs, including by creating some better connections to the similar Part D subsidy program that we often call low-income subsidy or extra help. Now, despite the intent of MIPA, as I noted, still millions of people who are likely eligible for the MSPs but not enrolled, including over 1 million people who are on that Part D subsidy program but not on the analogous Part A and B subsidy, the MSPs. Fast forward to this fall, September of 2023, when we, CMS, published a rule that codifies some of the provisions of MIPA and builds upon it. I won't get into the details here, but it's a set of rules that will dramatically simplify the application and verification process for the MSPs. In fact, we estimated that will save older adults and people with disabilities about 19 million hours of paperwork every year, and it'll reduce administrative burden for our state Medicaid partners by about 2 million hours a year. So a huge reduction in red tape. We estimate it'll get about 860,000 older adults and people with disabilities to benefit from enrollment in the MSPs. As progress, there's a lot more work to be done on this front. The next broadly shared policy goal we call advancing integrated care. And integrated care means different things in different contexts. Allison touched on a little bit. I'll say integrated care to me means achieving some level of seamlessness across Medicare and Medicaid, and also mitigating or eliminating some cost-shifting incentives across the two programs. But really, it's about creating systems that are more about the person than about the two programs in which they're enrolled. Now, the most natural way that we effectuate integrated care for this population is by having dually eligible individuals receive all of their Medicare and Medicaid services from one organization. We usually finance that approach through various capitated rate-setting methodologies. You can think of examples like PACE, the Programs of All-Inclusive Care for the Elderly, plus a range of other broader managed care options. More meaningful integrated care has been something that MACPAC and its sister agency MedPAC have written to over the years. I think a broadly shared long-term aim of having all or at least many more dually eligible individuals being enrolled in some form of integrated care. Now, in fact, enrollment in integrated care options has increased substantially over time. Back in 2011, there were only about 200,000 people in any form of what we would call integrated care. Now we're pushing 2 million people. That means over 20% of those full benefit dually eligible individuals in some form of integrated care. Nonetheless, Medicare and Medicaid remain separate programs with separate eligibility criteria, separate covered benefits, separate payment methodologies, and most dually eligible individuals remain in what we would call misaligned enrollment, which means they're getting their Medicare through one entity and their Medicaid through a completely separate one. And almost no one thinks that's a smart way for us to organize our healthcare system. 10 years ago, our work focused on creating new forms of integrated care. A big part of that was something called the Financial Alignment Initiative, through which we and partnering states created new demonstrations. We created new types of health plans called Medicare Medicaid plans, or MMPs. And in those arrangements, we had a three-way contract between the government payers and the organization. That organization was fully capitated and provided a fully integrated benefit package to individuals who enrolled with those plans. Meant accountability was clear. There were care coordination requirements, and we gave those plans really an unprecedented level of benefit flexibility. We also integrated a lot of administrative functions, some of which Allison referenced earlier, like appeals and grievance processes or materials that included all of Medicare and Medicaid information together, not in separate forms of documentation. Now, over the past decade, we've learned a ton from those demonstrations and the partnerships with states and others that we've built during the process. And in fact, our experience with those demos has very significantly informed some more recent rulemaking and policy development. In the meantime, Congress passed legislation related to organizations called dual eligible special needs plans, or DSNPs. These are Medicare Advantage plans that exclusively enroll people who are on both Medicare and Medicaid. DSNPs have existed for a while, but they had always been temporarily authorized. In the Bipartisan Budget Act of 2018, Congress gave those DSNPs permanent authorization. The law also required us to establish new minimum standards for how those DSNPs coordinate with Medicaid. It also directed us to unify the appeals and grievance processes across Medicare and Medicaid, much like we had done in those financial alignment demonstrations. And the BBA also expanded the types of supplemental benefits that MA plans, including DSNPs, can provide, really allowing plans to offer types of like non-traditional services that previously could only be offered either through Medicaid or through some of our demonstrations. More recently, a decade after the FAI demonstrations, a half a decade after the Bipartisan Budget Act of 2018, we're in a different world now. We're in a world in which enrollment in DSNPs and other forms of Medicare Advantage has exploded. It's a world in which choices are numerous, maybe even in some places overwhelming. And so while we continue to work with states to bring integrated care options where there are none today, we're also increasingly focused on simplifying a market that has, in some cases, become unbelievably complex. We've done some of that through recent rulemaking. As part of that, we are graduating those financial alignment initiative demonstration plans, those MMPs, into being forms of DSNPs, dual eligible special needs plans. That'll simplify the market in some places meaningfully. We're also tightening up this alphabet soup of different types of managed care plans and other organizations to help make options a little bit clearer across the market. And now, in some rulemaking that's out for public comment right now, we're proposing to limit the number of DSNPs in certain circumstances, to reorient Medicare special election periods to focus more on promoting integrated care options, and thinking a lot more about the choice infrastructure to try to ensure that people can make informed decisions and not be overwhelmed by the number of options that dually eligible individuals have. So there's been a lot of progress on these two big goals. We have more people in meaningfully integrated care. We have new ways to simplify enrollment in coverage that makes care affordable and helps people be more financially independent. But we have an incredibly long way to go. And this stuff, hard work, it's exciting and important work, but it's hard work. Some of that is with the federal government. A lot of that is with our partners in the states. And so we have to acknowledge that those states have their hands full already running incredibly important Medicaid programs. An important part of our work is, on the federal side, is try to provide some technical assistance and capacity for those states. We do a lot of that through something we call the Integrated Care Resource Center. But again, here we have so much more to do as well. Tom will take that in a second. So much more to do. And we know it's urgent because we're also doing a better job of listening to the people that we serve. Not a perfect job, but a better job. And doing that has helped to illuminate the fact that we got a lot more to do still to build a healthcare and long-term care system that's truly person-centered and that genuinely ensures access to the services to which people are entitled. Tom Betlach, take it from here.
Tim, thanks so much. Allison, Dennis, and Tim, very difficult acts to follow in terms of just the incredible presentations that you've provided, the overview, the depth, the stories, and thinking about not only the challenges of the dual eligible population, but also in terms of really some of the advancements and progress that has occurred over the last many years. And so I apologize, I don't have a presentation with fancy slides or wonderful quotes to go over, but I wanted to spend just a few minutes offering up sort of the state's perspective as it relates to how to be thinking about advancing strategies to better serve the dual eligible population. And I think Tim touched on it in terms of the different ways that states need to be thinking about the changes that have occurred in this space. This is such an exciting, important policy topic area. And there are so many more tools available today to states when you think about comparing that to maybe 10 or 15 years ago, and how states need to be thinking about leveraging those tools. So Tim talked about the dual eligible special needs plans, and now states with their contract with those plans through the state Medicaid agency contract have so much more ability to really think about the policies they want to achieve, the goals they want to achieve, and working with the stakeholders, as Dennis identified, in terms of being able to advance change in the system. There's more resources available today than ever before. Tim mentioned the ICRC in terms of resources that states can reach out to and really have in-depth, complex conversations, not only to better understand the different tools that are available as it relates to dual eligible strategies, but also to be thinking about, ways to advance their goals and what they want to achieve and how to think about that incrementally. And then finally, as Tim mentioned, there's more models that are available for states to really look towards and learn from. We know that states come at this, each state comes at it from a different place with a different system design, but it's important to be able to learn from the lessons that have occurred over the last 15 years. Have states have worked with stakeholders and they have pursued different models in terms of being able to advance care for the dual eligible population and reduce that fragmentation that Allison started this conversation with. I love data. I love to be able to look at data to help level set conversations. Allison highlighted some information that's out there from the MacPac data set, and I would strongly encourage you, if you're interested in this policy area and you haven't perused those documents, to go ahead and take a few minutes and do that. There's so much information that's available. A couple of data elements that I would share beyond what was in Allison's slides is when you look at what the delivery system looks like as it relates to how the dual eligible population is being served today. So the first is from the Medicare lens. When we look at the dual eligible population, 55% of the population in traditional fee-for-service program, 37% in managed care. And of those in managed care, Tim mentioned this, the growth of the dual special need plans, half are in DSNP. When you look at it through the Medicaid lens, you've got 42% of the population in fee-for-service, 20% that sit in some combination of fee-for-service and managed care. So that might be waiver services being delivered through a fee-for-service structure, and some of the acute or behavioral health services or wraparound services being delivered through a managed care organization. And then finally, 37% of the population in comprehensive managed care on the Medicaid side. So in thinking about the dual population and looking at the data, you have to not only look at it in terms of the separate lens of Medicare and Medicaid, but then also be thinking about, well, what does that mean for the dual eligible population and where they may be sitting, either aligned or unaligned as it relates to the overall delivery system. So there's some great data out there that didn't exist before in terms of having to be able to level set and better understand the dual eligible population. Allison did a very nice job of providing an overview in terms of the role of Medicare and Medicaid and who covers what services. And of course, Dennis talked about the importance of stakeholder engagement as it relates to some of the different subpopulations that are being served within the dual eligible population. And Tim talked about the tools at the federal level and the goals that people are driving towards I'm going to now focus on sort of the state perspective. And so when you think about states and you think about some of the subpopulation, Allison touched on fragmentation, but that fragmentation can be expanded even more within a state, because you might have aging services sit in a separate division or agency from Medicaid. You might have services for individuals with developmental disabilities also sitting outside the Medicaid agency, and behavioral services also may sit outside the Medicaid agency. And so the fragmentation that occurs between Medicare and Medicaid is oftentimes further enhanced just in terms of how state structures exist and how those services have historically been delivered. So we sit and look at this and we know that system design matters, but we also have, oftentimes some of the most complex individuals in some of the most complex fragmented systems. And so I think back to when I first started as the Medicaid director in the state of Arizona. For the individuals with serious mental illness, 45% in the state of Arizona were dual eligible members. And they sat oftentimes in a fragmented system of a separate behavioral health managed care organization, a separate physical health managed care organization for Medicaid. And then on the Medicare side, they might be in traditional Medicare and a Part D plan. So 4 separate systems just to deliver healthcare coverage, very fragmented, very poorly coordinated. And so thinking about the system design and how to advance goals at the state level to improve the integration that Tim talked about is so important. But then to do that through a thoughtful process in which, as Dennis identified, making sure that that is done with stakeholders and in a very collaborative fashion in terms of being able to build strategies to advance integration, alignment, and better improve service delivery models. So the first area I would emphasize in terms of thinking about this through the state lens is having dedicated staff that work on dual eligible issues. Oftentimes, state Medicaid agencies are strapped administratively. They think about the different areas that they're having to manage for just the Medicaid population. And oftentimes, there's not a focus in terms of how to think about dual eligible populations holistically and the types of resources that are needed to meaningfully engage in terms of all the different aspects of dual eligible policy setting. So states would want to consider potentially identifying a specific resource that can work on dual eligible issues. They can work on the state Medicaid agency contracts that I mentioned earlier, which really give the states a lot of opportunity and leverage to conduct significant policy through those SMAC contracts. So for example, a state may be able to limit the number of DSNPs in a market to those organizations that have Medicaid contracts if you have managed care serving the Medicaid population. There's also other quality expectations, health equity, reporting on supplemental benefits. We see states really now starting to push and increase their use of the SMAC to be able to drive policy within the state to look at ways to better integrate services. Tim talked about the proposed regulations. It helps to have a staff person within the Medicaid agency, within state government, to really be looking at those proposed regulations and thinking about how they impact the state's initiatives and dual eligible population, be able to engage stakeholders, get meaningful impact back from those stakeholders, and really be able to incorporate that into a thoughtful state response. The resources at a state could also help drive the different strategies and goals that the state wants to achieve around dual eligible population. Obviously through meaningful stakeholder engagement and being able to think about that as it relates to the different populations being served. I strongly encourage states to be thinking about a comprehensive data strategy. Oftentimes, states don't necessarily think about the disparate data streams that exist and how to connect them to get better insight into the dual eligible populations that they're serving. So states need to be thinking about, well, from the federal government, I receive the MMA file, and that tells me information on when does an individual become eligible for Medicare. If they're currently enrolled in Medicare, who are the plans that are serving them? And being able to take that information in and really be able to analyze it in conjunction with the Medicaid side of the house. And of course, on the Medicaid side of the house, you see information on what waiver services an individual may be enrolled in. And so being able to have a good cross-cut in terms of that section, and even be able to think about, how do I share that information with other organizations that would benefit from the dissemination of that information? So for example, the D-SNP plans would benefit from understanding what waiver services an individual may be receiving on the Medicaid side. A managed care organization in the Medicaid space may benefit from seeing some of the additional information that comes through in the MMA file. So being able to have a data strategy that thinks about all the information that's coming in, how you disseminate that information to improve care coordination, and then also in terms of how do you analyze that information to have a better understanding of your population today. What percent of the population that you serve that's aging is dual eligible? What percent of the population in the IDD for individuals with developmental disability are dual eligible? And what percent of the population for individuals with serious mental illness are dual eligible? All these different types of analyses really provide more insight, and I think will be more meaningful in terms of being able to go out and have robust stakeholder engagement and thinking about strategies and goals and objectives of where a state wants to drive towards in terms of improving and reducing fragmentation for dual eligible members. The third piece is really that stakeholder engagement piece, and I can't add a whole lot more beyond what Dennis already described, other than the fact that states need to be committed to this. They need to engage in this on a regular basis. They need to have different strategies as it relates to some of the subpopulations that Dennis identified. And it really needs to be done at the front end to help shape and inform. And then, of course, throughout the process, the states are looking to drive change and improve their overall delivery system. Finally, I would encourage states and individuals who are in states and looking to engage their Medicaid program on how to operationalize better systems of care for our dual eligible members, to really come up with a thoughtful strategic plan that identifies really your goals and objectives of how you want to advance care for the dual eligible population. Tim did such a great job of talking about the two goals at the federal level in terms of improving overall enrollment in the MSP and really to create more integration to reduce the fragmentation for dual eligible members. But states should also be able to identify what are your goals and objectives and strategies that you're identifying in terms of being able to improve care for the dual eligible population. We all know the challenges. I think that the panelists before me did such a great job of being able to describe the challenges that dual eligible members face. But the exciting part is there are so many more tools, resources, and models that states can look to in terms of how to improve care. And there's also resources out there available to achieve all this. So with that, Allison, I'm going to turn it back to you to be able to have more of a discussion and some question and answer.
Thank you so much, Tom. And thank you to Dennis and Tim for your presentations. I feel like I laid out all the doom and gloom of all of the challenges, and then you brought us some opportunity and optimism, thankfully, in terms of all that's happened, all the progress that's to be made, and the tools that are available to do the significant and important work ahead. So thank you so much for getting us to this point in the conversation where we can have more of a discussion. And I'm going to start fielding some questions, and thank you to folks in the audience who have been submitting questions. We are tracking those, and the good news is we have about 40 minutes for Q&A here, which is wonderful. So I'm going to jump right in, and Dennis, I'm going to turn to you first. Tim and Tom talked a lot about the advancements in integrated care programs for dually eligible individuals, particularly post-ACA through the financial alignment demonstrations, through the D-SNP platform, et cetera. You are a person who's been actively engaged in Massachusetts in the rollout and design and ongoing implementation of integrated care programs through Massachusetts. And I'd love for you to tell us a bit about, in your experience, what difference has it made for you to be in an integrated program in terms of navigating the supports and services that you need, both in terms of the positives and where gaps remain?
Sure, thank you. I am someone who firmly believes in integrated care, whether it's through a PPO, a PACE program, DSNP, or some other, an ACO, whatever it may be, that there'd be different models. Because I just personally can say that my mom had really complex medical needs due to an autoimmune disease that resulted in her having kidney failure, but there's no one coordinating her care at all. And so as a result, my mom died from lack of having really good care coordination, which is the opposite of my story, which is I've had care coordination from the last 30 years. I actually ended up in the hospital one day, and predates all the innovations that have taken place. But a plan started by Dr. Bob Master, Community Medical Association, the Community Medical Association, and I've had coordinated care for all these years, and so I wouldn't know what to do without coordinated care. And when I say coordinated care, I mean, at least back then, things have changed since then, where the locus of coordination took place in my home, whether it was a nurse practitioner or a PA, a physician assistant, who was in my home, who knew me, knew my family or my personal care attendants, or saw firsthand the service already required, and really help coordinate access to the different services, whether they be medical or LTSS or whatever the services might be. And as that's changed over time, now I have a telephonic care coordinator who is somewhat part of my care team, but not part of my care team. And that telephonic person helps me with things like access to transportation, which is phenomenal, because when I have to go to a medical appointment, if that transportation does not show up, that care coordinator will assist in ensuring that that transportation actually gets there, or will follow up and make sure that it doesn't happen again. For other people, that care coordinator can help facilitate access to, I'm going to stick with very simple things like access to medical supplies, and ensuring that people have the medical supplies that they need. And things like urinary tract infections, or so simple issues like that. Um, and so I think the other huge benefit from integrated care is the integration of behavioral health and medical services, where if you've got a good care team that's integrated, you've got folks who are looking at the whole person, and that whole person's needs are being met. We've got the medical providers and the behavioral health providers working together. And I would add into that, in Massachusetts at least, where there's also integration of certified peer specialists and recovery coaches, so that you've got peers and engaged in the teams with people, working with the person to meet their goals. So I think, in that sense, my experience has been it's an ever-changing program. We do have concerns about the shift from the Medicare Medicaid plan to the DSNP, with the difference with now we've got, rather than a three-way contract, we're going to have separate contracts between Medicare and Medicaid, and what that will do, how that might impact seamless integration of services and all sorts of things. But I would say in general, we're very pleased. I think I should say that the model of care that we have, the inclusion of peers at different levels, inclusion of a long-term service and support coordinator, all these are innovations that Massachusetts advocates worked with the state to include. And these are not just things to improve the quality of life for members, but they can reduce costs. They can lead to savings for plans. And I'd say, I think, did I answer your question?
We could listen to you for hours, but
Yeah.
yes, you absolutely,
Okay,
and
that's
feel
fine.
free to say more, but you absolutely answered the question.
I guess I'd say the challenges that we're facing right now are some of the challenges. I think I was glad that I really appreciate so much what Tom said. And is we need a third title. We've got a Medicare title, we've got a Medicaid title. I really think we need a dual title, one that's going to ensure that the resources for states are there, so we don't have the inequities in access to services we have today between folks in Oklahoma versus Massachusetts or Mississippi versus Minnesota. So there needs to be some way of ensuring that also this is, I think, what Tom said, is that the states don't bear the burden, the financial burden of rebalancing spending. Because right now, when states invest in LTSS and other Medicaid services to keep folks out of hospitals, Medicare benefits. And so we need to make sure that Medicaid, that states benefit from those savings, and that there's incentive for those savings. I also think there need to be real value-based purchasing innovations put in place so that we define what value is, and that we're ensuring that plans and other entities aren't just using fee-for-service payment models, but they're actually using models of payment that lead to better outcomes for members. And in terms of measurement, because Tom mentioned that is when we're looking at measuring like reduced hospitalization rates or reduced nursing home rates, that we also look at increased integration in the community, reduced isolation and loneliness, or look at ensuring there aren't increased reliance on antidepressants or anti-anxiety medication, but that people are actually engaging in the community. And we want to see those measures as well. And I'll stop there.
For now.
Yeah.
Thank you, Dennis. So much in there. You've given me so many jumping off points to bring the other panelists into the discussion. One of them, Tim, that Dennis just mentioned is the question about state level incentives to invest in integrated care programs. And as Dennis alluded to, we often hear that a barrier to states pursuing Medicare, Medicaid integration is that the investments they make on the Medicaid side would likely result to savings to Medicare through reduced hospitalizations and emergency department visits. I'm curious for your thoughts on that, and particularly as you think about the move from the demonstration to an increased focus on the DSNP platform. Do you see opportunities for states to realize Medicaid savings from integrated care programs in this landscape?
Yeah, it's been an article of faith for a long time that that state investment equals Medicare savings. And I think we can easily think of good examples. If I have better access to in-home supports or better access to certain forms of community-based behavioral health treatment, I'm less likely to end up in the emergency room. Those examples are real. We haven't solved this completely, but I think we've found some ways to mitigate it really significantly. So first, we've written about, published in the Federal Register last year, ways that states in the context of capitated managed care could use some of the rules around actuarial soundness and capitated rate setting to better recognize some of the dynamism between Medicare and Medicaid when people are in certain types of integrated care programs, to ensure not necessarily that states can completely capture all forms of that savings, but there are lots of tools that they can use, some of whom have already used it, to better balance the investment side of that equation. So that's number one. Number two, I guess, as some of the things we've learned from the Financial Alignment Initiative demonstrations is that what happens from an integrated care product isn't as completely linear as that narrative always leads us to. So, for example, we have multiple states in which there have been statistically significant reductions in long-stay nursing facility placement, where we've implemented integrated care options. So I think it's just, it's not that it's untrue, it's just that the narrative is a little bit more complicated than like state investment equals Medicare savings. I think the reality is more complex than that. What I would also note, I mean, it's really, I do it too, and it's really tempting to always focus on like the very crass economic kind of financing here. And there's an important reason for that, which is that the state Medicaid agencies operate in a balanced budget world, and that forces them to almost always be a lot more thoughtful about investments than frankly we often have to be at the federal level. That being said, there are state leaders from coast to coast who also have goals here to reduce disparities, to improve outcomes, that I wouldn't say completely obviate the need to balance the budget, but also I think mean that there are a lot of state leaders who have invested in these things, not simply because they want to save money in the Medicaid budget, but because they have other objectives, and that's often to reduce disparities and improve outcomes.
Appreciate that. It's a great segue, Tom, to you. Would love to hear your thoughts on this question of sort of the case making at the state level. You've sat in that chair. You work with states across the country, and would welcome your thoughts on, how much do states need to be sold on whether this is, this should be a policy priority, how much it's top of mind, and I can add questions from there, but would love your initial reaction.
So Allison, I'm going to completely ignore that question for like 30 seconds, and then I'm going to come back to it, okay? Because I think Dennis said something that was so important, and I just wanted to touch on it for folks that are out there and just sort of thinking about the big picture of the dual eligible program. And that is 60 years ago, almost 60 years ago, when Congress created Medicaid and Medicare, I doubt they were thinking of a population like the dual eligibles that would grow to be over 12 million individuals and represent some of the most complex cases in our country, and the different fragmentation points that would result not only between Medicare and Medicaid, but also like just within the Medicaid delivery system itself. So, Dennis mentioned like this new title notion and how to really, completely step back and rethink about dual eligible members. And, a lot of my peers, former peers in the Medicaid space are doing a lot of great work to try and improve delivery systems for dual eligible members. But I also think it's a legitimate conversation to be had at the federal level and engaging states. And of course, stakeholders and different populations need to be around the table. But I do think it's an incredibly important policy point that Dennis raised, and I just wanted to circle back to it for 1 minute. So to come back and answer your question, I think clearly when you look at the opportunity to move the needle on improved outcomes and reduced spend, that spend from a broad public perspective, coming up with strategies around dual eligible populations is critical for a Medicaid program. One of the major constraints is that a Medicaid director's tenure is less than 2 years, that most states don't have the type of staffing that I mentioned earlier in my presentation, where you have individuals that are focused on advancing dual eligible strategies. And thus, as a result, this topic oftentimes gets placed down on the priority list. There's other areas that rise to the top based upon either what's happening at the federal level, at the state level, with regards to budget and other things like that. And unless you can actually get leaders that have some continuity, that can look at, because we all know that doing this work, although very important, takes a lot of time. Tim laid out things that were accomplished over the course of 13 to 15 years, right? And so if you have people that are turning over every 2 years, it's really difficult to continue to keep the dual eligible topic at the top of the list and to move it forward. And that's why I think, when Congress and others think about how to continue to engage states on this topic, having something like you have to have a state dual eligible plan, and we're going to provide some resources to help you support that, is an important policy discussion to have, because something needs to keep the dual eligible population near the top of the list for Medicaid directors, because just the natural turnover in conjunction with other priorities oftentimes results in it not being a priority.
I appreciate that, Tom, and you're forgiven for ignoring my question first and starting answering another question. So it was a worthy pause there. Dennis, I'd love to hear you react to what Tom just suggested in terms of the notion of a mandate to states. You mentioned in your earlier comments the equity issue across states. If you're a dually eligible individual living in one state versus another, what might you have access to or not have access to based on what level of prioritization these policies have garnered in one place versus another. So I'm curious, in your advocacy work, in your discussions with advocates and policymakers across the country, do you think that a mandate is what we need? Do you think that we can make enough progress across states given just the increase in the sort of voluntary tools and incentives that are available to support this work?
Yeah, thanks. First, I'm going to start with equity even in access to decision making. And CMS, the rule change that went through, I want to thank Tim and his team for ensuring that there's, with the MAC and the bag, I hate that acronym, but the MAC and the bag, ensuring that there's actually engagement with folks across the country in policy development. That's a huge advancement, and that's a way of advancing equity by bringing different populations around the table and having them impact policies at the state level. And so regardless of what's available in that state, that what resources are available, that those resources are being used in a manner that reflects the priorities of the folks whose lives are affected by those policies. So, and there's a new rule that's coming out that we're going to be responding to, again, like, advancing the voices and integration of services for folks. And so like that's a form of equity that doesn't require a lot of resources, but it's really about doing things differently. And so it's not, I don't think it's just about creating a new act. The reason why I do think that that's something that needs to be discussed is that I don't think there's going to be equity across states because the resources are just different. But ensuring that there's equity in terms of how resources are used or how resources are used, but ensuring that states are incentivized to use their resources to reduce hospitalization rates and to invest in community-based services, that states have greater competency and capacity. As you said, like, Tom, 2 years, that's absurd level of turnover. And even in Massachusetts, where we do have a lot of resources, we don't have a Medicare expert in state who can actually shape or smack a state Medicaid contract for the DSNP in a way that is really informed from the Medicare perspective. And so by having a third act, it might reduce some of the burden of states administratively, so that they actually are all working from the same perspective. So it's not just about finances. The financial piece is far more complex than I think we can get into today. But I think there are some administrative pieces of this that can be looked at as a starting place, and then get into what do the finances look like in terms of that third title. But I do think we need to move in that direction. We should move in that direction because the population is so complex. It varies by population, by age, and every state's population is different. And so each state, how it's going to invest those resources may vary because depending on the population, depending on whether it's urban or rural. So, and that goes beyond the scope of this conversation. But to say to moving that direction and moving conversations that way, I think is really important.
And Allison, under my mandate, I was thinking States are required to do quality improvement plans that they submit to CMS. They're required to do health information technology plans. What's wrong with having a dual eligible plan that identifies the strategies that a state wants to advance in exchange for some additional administrative resources? I think, everything Dennis laid out in terms of broader equity across states is a really important discussion too. But I'm a firm believer in incrementalism, and things change incrementally over time. And so, in order to do that, just sort of level setting on the playing field as it relates to the capacity of a state Medicaid program, and sometimes having a tool to try and keep dual eligible issues front and center, I think that's something Congress should be interested in.
Really appreciate that, Tom, particularly in the context of turnover in state leadership, the complication of building Medicare capacity and some of the data infrastructure and so forth that you talked about in your remarks earlier, and recognizing that some requirements alongside resources to support that work and to act upon the information put forth in a plan is a really important complement to a requirement itself. And we can talk more about that. Tim, I want to turn to you. We've been sort of pie in the sky a little bit here about what a perfect solution might be, or what might come through future legislation or what have you. But as you mentioned in your remarks, we've got a lot of tools today, and there are a lot of opportunities that are not yet fully tapped in terms of increasing enrollment in integrated programs, as well as increasing what's available to beneficiaries within those integrated programs. And so I'm curious, from your perspective, in terms of what we know today and what we have today, what policies or which of those tools do you expect to generate the biggest gains in integrated care over the next 5 years? What gives you the most optimism at this point in time?
Well, the biggest asset that we have, all the states have, is the expertise of the people we serve, and how we tap into that meaningfully can vary in different ways, and sometimes it's easy and sometimes it's hard. We ourselves have learned a lot from various human-centered design projects, including on some of the eligibility related stuff I talked about. Dennis just alluded to a proposed rule that would require every state Medicaid agency to have a beneficiary advisory group associated with its statewide Medicaid Advisory Councils, or generally called. We ourselves finalized a rule requiring every DSNP to have an enrollee advisory committee. So we're learning. We got so far to go, and lots of those things proved to be a little bit of lip service and not always like the genuine thing they are meant to be. But I think as a community, among the states, CMS, the like meaningful recognition that when we talk to the people we're trying to serve, we do better at serving them is like a real thing. And so to me, that's like asset number one. And as alluded to, like that cuts through differences in resources to like any state should be talking to and learning from the people that are enrolled in that state. So that, to me, that's like asset. I don't want to call it a tool that feels so wrong, but it's like asset number one. In a more bureaucratic sense, half the people we serve now are in Medicare managed care. And in many of the most populous states, virtually all of the dually eligible individuals are in Medicaid managed care. And Tom alluded to something called the State Medicaid Agency Contract. This also came out of federal statute, MIPA, as I mentioned earlier, in which Congress said these dual eligible special needs plans can operate in any state contingent on having an agreement with the state Medicaid agency to operate there. And in establishing that requirement, Congress didn't put many bounds on what the state could require in those contracts. And so Tom alluded to the fact that you could say, we're only going to contract with a DSNP in the state if, in fact, they participate in Medicaid, if they achieve certain performance improvement objectives, like whatever, we can work in there. That is a tool that is given to the states. We at CMS review those contracts to ensure they meet minimum requirements, but states have increasingly used that in thoughtful, constructive ways. And so to me, in like the very crass bureaucratic sense, those are the most powerful tools we have right now to effectuate change in a world in which, let's face it, the majority of people now are in capitated managed care systems.
Thanks for that, Tim. I'm going to stay with you for a second, and I'm going to turn this question to Dennis and Tom here in a minute. But we got a question from the audience that points to some of the discussion earlier around the explosion of choice in the market, and how there are, in some places, there's more sense making to do for beneficiaries than might be necessary or useful. And a specific question we got is about any changes that would be helpful to the Medicare Plan Finder, for example, to improve beneficiary education on their choices. And Tim, welcome you to comment on that question and more broadly on this issue. And then Tom and Dennis, I'm really curious for your perspectives on this question as well. The broader question around choice and how do we simplify choice for folks?
You first. For me, a place to begin, one starting place, is to do away with lookalike plans. That if an insurer has a dual eligible plan in the state, that they're contracting through the state, that they not be permitted to have other Medicare Advantage plans that look like their contracted plan through the state, but don't provide the same level of services that are available to the dual beneficiary. Because duals are bombarded by advertisements promising them this service or that service that don't necessarily come through, and there is a plan out there for them that is contracted through the state, that's partnering with the state, that ensures there's a minimum number of services they can get. So I think for me, a place of winnowing sort of the choices to real choices is to start there. Is to get rid of the false choices and focus on the ones that are actually going to meet folks' needs or there's a basic minimum standard.
Dennis is alluding to something we call DSNP lookalikes, which are Medicare Advantage plans that largely or almost exclusively serve people who are dually eligible but don't meet the requirements of being dual eligible special needs plans, like having an evidence-based model of care and conducting annual health risk assessments and contracting with the state Medicaid agency. And that's an issue on which we have an open rulemaking proposal right now. Similarly, that same proposal, we're soliciting comments on the choice infrastructure, a big piece of that being Medicare Plan Finder, which is this incredibly powerful tool that helps people identify plans that fit best for them. Currently, that's a tool that doesn't have business intelligence kind of like connected to the Medicaid program. So we're not necessarily showing you that among the literally 100 options that you may have in Cuyahoga County, Ohio, we're not really leveraging it to put at the top of that list, like, here's the Medicaid plan you're currently enrolled in. And we want people to have a lot of choices. And if they're not satisfied with that plan that they're currently in when they're newly eligible for Medicare, we want them to be able to make good choices. But we also don't want to make it excessively difficult to find something that is designed to blend together your Medicare and Medicaid services. So there's a lot more we can do on that front, building on an incredibly powerful tool. Dennis also noted the proliferation of marketing activity, other things that we've got some proposed rulemaking on that make it just an incredibly dynamic market for people right now.
Allison, I really don't have much to add. I would just come back to my example I gave earlier in terms of, there's a state out there, it established an MLTSS program, Medicaid Managed Care for Long-Term Services and Supports, and it basically indicated to the market that anybody that didn't get that contract would need to exit. And that resulted in, the market going from 10 plans to 3 plans. And so, that's a conscientious decision the state made, leveraged its authority through the state Medicaid agency contract, and was able to, I think, more align the choice in the marketplace with those plans that actually were in the Medicaid space. So I know it's a repeat, but I wanted to give just a specific example of where it's been.
A great example. Yeah, thank you for that, Tom. It's a great example, and it's an example of, in some cases, states increasing their awareness of their ability to do things like that, and limit decent contracting and put constraints on what choices are available to their beneficiaries. So thank you for reinforcing that.
If I just say, I also think that in some states there aren't a lot of choices. There may be choice of plans, but they're all the same plan. And so they're just managed care as opposed to a PPO or some other, or an ACO, whatever it may be. But I like PPOs, but just that there be some sort of other options that people have other than just a managed care plan. And so when we say choices, if they're all somewhat cut from the same cloth, the same model in some ways, that's not necessarily offering choice. It may just be nuanced choice as opposed to real choice. So I think we really have to define what we mean by choice.
Dennis. Tim, you mentioned a moment ago the term model of care, and that came up in one of our audience questions as well. From your perspective, can you help our audience understand what's the role of the model of care in DSNPs, and what's the opportunity with the model of care specifically as it relates to improving integration of care for the dually eligible population?
By law, every special needs plan has to have what the law says, an evidence-based model of care, gets submitted to NCQA, who reviews and approves those models of care for some period of time. Done right, it's a blueprint for how a managed care organization is going to serve a special population in a way that's different from their kind of commercial traditional business. So that's an opportunity to lay out, here is how we're going to develop a health risk assessment and implement it in a way that's cognizant of the fact that people may be receiving Medicaid home and community-based services as well. Or here's how we fold peer support into our approach to serving people with who need behavioral health services, right? So this is the opportunity to kind of customize the approach in a way that's different from I guess what we would call kind of cookie cutter, commercial style managed care. Now, we have seen variable kind of development of those models of care in how well they integrate the Medicaid piece of the equation. And in fact, I've recently worked with states to kind of add Medicaid elements to the models of care themselves. So in states like Minnesota and Massachusetts and California and elsewhere, worked with our state partners so that process kind of baked in is you've got to address in that model of care how you're achieving certain policy objectives related, in the case of California, related to dementia care services, right, others. So we tried to, with many things, we tried to better coordinate both the federal and state side into a document that's largely meant to be the blueprint. Now, it's not just some aspirational thing. We have teams of people here at CMS who go out and audit health plans, and when they audit a special needs plan, they audit with that model of care in mind to ensure that the organization delivered services in the way that they laid out in that approved model of care. So it's a real thing that drives both the approach to coordination of care, but also our approach to compliance related to that.
Can I just build on that, Allison?
Yeah, absolutely. And I'm going to say, Tom,
but you come at it through the state lens, and there's so many opportunities in the model of care. I mean, it's 200 pages plus usually of a lot of detail in terms of what the plan needs to be doing and how they're thinking about care management, care coordination, and member engagement, and all of those important topics. But Tim was describing this. It's a real opportunity for Medicaid to come in and make sure there's alignment between what the integrated care team looks like and who's the point in terms of care coordination and care management for populations. I've also strongly encouraged states to be leveraging the model of care to be very specific, as Tim was talking about, to the state that you're in and lay out the fragmentation points and how they're going to care coordinate, and know that if IDD, long-term care services on the Medicaid side, are done by a sister state agency, that's who they're coordinating with in terms of if somebody is in an inpatient setting or an emergency department, that they need to coordinate with that entity, or if there's behavioral health services and they need to coordinate with a behavioral health entity in the state around that, or at the provider level. Some states prefer, you know, particularly for certain populations, that care coordination be done at the provider level. So, you know, it's sort of, you know, it's more like graduate level work on the dual space and how states should be thinking about it. But there's incredible opportunities to be very specific in terms of what the expectations are within that model of care for the plans, to make it identify and be used as a tool for that state and the unique aspects of that state.
This is going to sound a little, the first plan I was a member of, the first capitated plan, CMA, their model of care was based on the idea of the dignity of the person and advancing independent living, and when they didn't have at the time recovery model, but recovery was implicit in it. And so it's so healthcare is not just a means and an end, but healthcare is a means towards supporting people's civil rights and their dignity. And really important ways of doing that are through in operationalizing independent living principles. I mean, we would not have HCBS if not for the independent living movement. We would not have the institutionalization of people with psychiatric or mental health diagnoses if not for the recovery movement. And we know that those dignity and civil rights based models work, and if the medical system would and these other systems partner together, you get much better outcomes, and I think more engagement of folks in society, and improved health outcomes, and just than we have today. If we just try, as Tim was saying, is that single model of care that says, you know, that's basically one way of doing things, and we're always trying to fit that square peg into the round hole. It's just not going to work. The commercial models need to shift to ensure that they're actually designed to meet the needs of the populations that they're being paid to serve.
Amen.
I'm going to give you each a second for a parting shot. We have about a minute. If there's anything, you know, top of mind that you just really want to underscore here in terms of the opportunity before us, I would welcome your thoughts on that. Tim, I'll go to you first.
If you're with a state Medicaid agency, call me, because we're here to try to be helpful to you. And every state, resourced however they may be, can benefit from doing more to talk to those people who are dually eligible in the state and learn from their experiences and drive it towards improvement.
Go ahead, Tom.
If you're with the state, put something on your list for 2024 that you're going to do to advance overall care for the dual eligible population.
Dennis.
And I'd say I have deep respect for Medicaid directors around the country and for CMS and what you're trying to do. And I think we have that what you put together, Tim, and moving towards more integration of the voice of folks who actually benefit from the service or access these services, I think is really important to be done in an authentic way and in a measurable way, so we can actually see how the voices of folks who utilize these services impact policies and what the outcomes are from those policies. So I think that's a really key step in this.
Well, I want to thank you all for a really powerful discussion today. You have shared so many practical suggestions with our audience, and I'm just greatly appreciative for all your continuing efforts in this space. And Allison, I will turn it back to you to close us out.
Great, thank you. Thank you, Allison, Dennis, Tim, and Tom, so much for joining us and for all the important work you do to improve policy and healthcare for dually eligible individuals. I want to thank all of you who took the time to be here with us today. We hope you found this discussion informative and will be able to take what you learned and use it in your work. I also, again, want to thank our wonderful sponsors, the Association of Community Affiliated Plans, the SCAN Foundation, Santa Clara Family Health Plan, and the Health Plan of San Mateo for their support of this work. And we want to hear from you. We appreciate all of you in our community and our network. We want to know what we could be doing better, what we could be bringing to you in terms of resources and information. So please feel free to share that via email or complete our evaluation survey, which we'll put that link in that chat there. Here at the Alliance, we host educational webinars and in-person events throughout the year. So please do follow us on LinkedIn or visit our website or sign up to receive email updates about our upcoming events. We invite you to join us in January for our annual health policy forecast. And please keep an eye out for that invitation to register in the new year. As a reminder, a recording of this webinar and additional materials will be available on the Alliance website. This concludes today's webinar, Navigating Complex Systems, Care and Policies for Dual Eligible Beneficiaries. Thank you so much for joining us today.